Greetings. The voice you hear is AI generated. The work presented is done man-made. My name is Kermani, and I have been practicing ophthalmic surgery at a private clinic in Cologne since 1993. I would like to express my gratitude to the organizers for the opportunity to present this recent development, fully aware that many of my colleagues hold opposing views regarding the use of anterior chamber lenses. A 24-year-old woman underwent surgery for a unilateral congenital cataract at the age of 1, resulting in aphakia. She has worn an aphakic contact lens since childhood. Her visual acuity is 20/25 in the aphakic right and 20/20 in the left eye, with an endothelial cell count of 2,900 in the aphakic eye. The presence of posterior synechia between her pupil margin and the remnants of the capsular bag prevents access to the ciliary sulcus for a scleral fixated intraocular lens. There are limited options for treating aphakia. Because there are concerns regarding anterior chamber lenses, off-label alternatives, such as the retroiridial fixed Verisize lens, has become the treatment of choice for many surgeons. Additionally, several transscleral fixation methods for placing a posterior chamber lens in the sulcus have been developed. These techniques need time, skills, a set of special instruments, and as any other secondary method of IOL implantation, these methods are not free of potential complications, not only because of the high age of the patient group. Comorbidities are also common here. However, none of these options seemed suitable for my patient, being aphakic without access to the sulcus and a posterior iris that was largely grown together with to the remnants of the old capsular bag. Therefore, I recommended that she return in a year while I explored potential solutions. In fact, it took some research and development effort, and after more than 2 years I could offer a treatment to my patient. Olaf Morcher, CEO of the Morcher company in Germany, approved my proposal and brought the idea to life. The new anterior chamber lens, made from foldable hydrophilic acrylate, has an overall diameter of 12 to 14 mm, depending on the patient's white-to-white measurement, and features a 5 mm spherical optic. It includes 3 haptics arranged symmetrically in a Tristellian pattern, angled to allow smooth flow of aqueous humor without the need for iridectomy. The following video demonstrates the implantation of a +16D diopter Morcher Type37F anterior chamber lens with a total diameter of 13 mm. The width of the paralimbal incision is 2.5 mm, the pupil was constricted, and the anterior chamber was filled with viscoat as an OVD before the intraocular lens was implanted using a standard Monarch injector from Alcon. The spiral configuration of the haptics ensures the correct positioning of the lens in the anterior chamber. The entire procedure took no longer than a few minutes and was performed under topical anesthesia. Post-op dexagentamicin eye drops are administered for 1 week. The postoperative course was uneventful, with satisfactory refraction and visual acuity. 12 months after implantation, the anterior chamber intraocular lens is well tolerated. Following an initial slight loss of endothelial cells due to the surgery, the endothelial cell count has stabilized. I would like to share additional indications for the use of this anterior chamber lens model. For instance, there was a case involving complicated cataract surgery in an elderly patient with a generally poor health status, where the new IOL acted as a rescue lens. Fuchs ED was noted for both of the patient's eyes. However, the new lens was well tolerated for 12 months after implantation in this case as well. The documented loss of endothelial cells is primarily attributable to the complications of the cataract surgery. We are observing an increasing number of cases involving a dislocated IOL in the bag complex. It is anticipated that nearly 2% of all cases may occur after an intraocular lens has been in place for 20 years. This trend should serve as a warning, especially with the rising number of refractive lens exchanges in younger patients. However, most affected patients are older, and a well-functioning anterior chamber lens could provide a simple and quick treatment alternative with an expected wearing time that is significantly shorter compared to a posterior chamber lens in the bag. In the case presented here, the postoperative course was also satisfactory. The Morcher Type37F anterior chamber lens implant shown was successful following the explantation of the dislocated old posterior chamber lens complex and an anterior vitrectomy. As in the other cases, the indications for the new lens were probably well balanced. The patient is over 80 years old, in poor general health, and the eye is highly myopic. The surgery, performed under topical anesthesia, provides comfort to patients. The foldable, hydrophilic, Acrylate anterior chamber implants are customized for size and designed to be astigmatism neutral with a 2.5 mm PLI. This atraumatic procedure does not require iridectomy. Patients recover quickly after surgery, with monitoring conducted through slit lamp examinations and endothelial cell count measurements. It is important to be cautious about using implants that are too small, as this can lead to pseudophacodenesis, which may result in poor tolerance of the anterior chamber lens. Additionally, care must be taken to avoid upside-down implantation, as this can cause pupillary blocking. We inform our patients that long-term postoperative monitoring is essential, and prompt IOL exchange may be necessary if adverse effects occur. The reversibility of this method is a significant advantage. Please note that no study results are yet available for the Morcher Type 37 anterior chamber lens. The cases presented are individual treatment trials. Patients were informed about alternatives such as the rigid Kermani lens and intraocular lenses with sulcus or iris fixation, and they provide consent for implantation. The Morcher anterior chamber lens is manufactured and delivered as a custom-made medical device in 4 to 6 weeks after prescription, in accordance with European MDR Article 2.3. Thank you for your interest, and if you have any questions, please feel free to contact me.